up, we have Dr. Fauna Smith joining us to speak about caprine arthritis encephalitis virus. Dr. Smith is the Assistant Professor of Livestock and Herd Health and Reproduction. Her expert at UC Davis. Her expertise is in immunology and infectious disease. Her research interests are in the areas of small ruminants, emerging diseases, immune development and sex differences in ruminants, the development/assessment of herd health preventative measures for infectious diseases. Dr. Smith is boarded in large animal internal medicine, and her clinical focus is in small ruminant herd health. Her research interests include immune characterization of sheep and goat, field research on a novel approach to prevent gastrointestinal and respiratory disease in sheep and goats, and biosurveillance of California's small ruminant population and the emergence of infectious diseases. So thank you so much, Dr. Smith, for joining us today, and I'll let you take it away.
Thank you for the invitation to talk with this group. Today I'm going to talk to you guys about small ruminant lentiviruses, and we're going to focus on CAE or caprine arthritis encephalitis virus. But I will talk a little bit, and I do have some slides that are actually slides of sheep with Visna or OPP. It's not going to let me go forward. So just as a reminder, there are a whole group of small ruminant lentiviruses, and traditionally we've kind of classified them into Visna/ovine progressive pneumonia, depending on what continent you live on, and caprine arthritis encephalitis virus. Really, probably the most proper nomenclature to use would be to refer to them all as SRLVs. And then within SRLV, we have strains that are more OPP-like and the strains that are more CAE-like. My lab actually is studying trans-specific infections, so looking at commingled herds of sheep and goats and looking at what viral strains exist in positive herds and how that might correlate or not correlate with clinical disease. So lentiviruses are retroviruses, and so retroviridae are characterized by being a single-stranded RNA virus, and the really unique thing that they do is that they have reverse transcriptase, which is basically an enzyme that allows them to make a DNA copy of themselves, insert it into the host genome, and then co-opt the host's genome in order to be able to make the virus. And so when we think about that and the way that the virus is made, again, the outer surface of the virus is actually self. It's the cell membrane of the mammalian host, along with proteins that have been encoded for by the DNA that's been inserted into the host genome. Because it inserts itself as this provirus into the host genome, we think about these as being persistent, be cleared, because there isn't really an antigen that the immune system can detect and then prevent or clear or neutralize, because that host genome is now carrying the viral genome. And that kind of lifelong infection becomes really important when we start thinking about how to try and control or manage or test for this disease. So a little history on caprine arthritis encephalitis virus. The syndrome was first identified in the 1970s as this kind of chronic progressive arthritis, poor doer syndrome. And along with that, there was descriptions of juveniles in heavily infected herds that presented with ascending paralysis. And then when you looked histologically, the lesions were actually in the brain. And so there was this encephalitis. And so we came to refer to this as caprine arthritis encephalitis. The virus was isolated finally in the 1980s And then we started to see farms institute the first CAE targeted control programs in the early 1980s. What I will say is that in the 60s and 70s, especially in dairies in California, there were actually some really big issues with Mycoplasma mycoides subspecies, mycoides large colony, now called Capri. And the first control programs that took care of CAE or helped with CAE were actually instituted for mycoplasma. And then those herds that did that, even though they didn't know what the cause was at that time, started to see changes and reduction in the amount of clinical disease they were seeing of this progressive arthritis that they had in their herds but did not know the cause. Pasteurized rearing programs, for example, were actually for mycoplasma and incidentally helped to take care of CAE. And I don't know what the producers on or the veterinarians on this call, what your producers, whether you have mostly commercial producers or whether you have seed stock or show herd producers. I find in the seed stock and show world that they've completely forgotten about mycoplasma, and they think as soon as they think they have CAE under control in their herds, they stop doing the targeted programs, control programs, and then they end up with mycoplasma. So kind of an aside. So when we talk about small ruminant lentiviruses, there's kind of four clinical presentations or syndromes that we see with small ruminant lentiviruses. And again, I actually dislike the name CAE for the virus because it misses out of two very significant clinical syndromes that this virus can cause. And so the one that we kind of classically think about in goats is this proliferative synovitis. And I call it synovitis because the actual major pathology is in the synovium. It's not in the joint. So if you look histologically at this, it's inflammation and calcification of the synovium with actually relatively minimal, like true articular arthritis. Um, and we do tend to see the carpi. You can see in this doe here that this is kind of the classic big need CAE animal. And so carpi are by far the most easily seen by a producer and appreciated, but it can happen in other joints. And then we have interstitial mastitis, the progressive interstitial pneumonia, and then at least in my practicing career, I've been a veterinarian for about 25 years. It's actually the ascending paralysis is actually rarely seen anymore, whether that's a change in viral strains, a change in viral load that our animals are experiencing. I can't say, but I do feel like clinically I don't see that syndrome very often. Just to kind of look at some really good examples of these different syndromes. So you can see here in this alpine doe standing on the milk stand that this hock is super enlarged with kind of this big knob off the side. And again, this is the synovium that has become calcified and proliferative. Kind of the classic carpi, and then another doe with the classic carpi. When we talk about interstitial mastitis, from a production point of view, there are lots of goats with big swollen knees that actually still remain relatively productive in their milk careers. The hard bag mastitis really is like one of the major production limiting parts of CAE or small ruminant lentivirus. And it's because the milk producing tissue is being replaced with fibrosis. And so like this is actually a sheep or a ewe with hard bag, but this ewe freshens and my producers look at her and like, oh my gosh, she made so much milk. She's, gonna do great. And then you go and look at her lambs and they're weedy little things that aren't growing, and you go and touch this udder and it is just fibrotic feeling. It's just hard and fibrotic. And, when you cut it open, It's this kind of pale, there's not a lot of the ducts have kind of been replaced by this interstitial fibrosis and inflammation, typically lymphocytic inflammation. This doe over here, this Nubian doe over here, again, in dairy goats, in highly infected herds, what we tend to see is yearlings, so first fresheners, that as their mammary gland starts developing, instead of developing productive glandular tissue, they develop hard bag right from the beginning. And so they freshen with these big udders. They're typically a little abnormal or altered in shape because they actually never get much secretions in them. And they're just these like hard, lumpy bags. And in older does that are, say, infected that don't freshen with hard bag themselves, you will notice with every lactation that at freshening, it'll be a little more firm or swollen than you would kind of consider for a normal doe, and their production is limited, maybe not to the same degree that the heavily infected yearlings are. We also will see an interstitial pneumonia. Now, this is the classic presentation in sheep, and you'll actually, let's see, if you watch this, you'll walk out into a pen of sheep or goats. It is much more classic in sheep. And they're standing there breathing like this, very kind of labored breathing. You'll see kind of abdominal press. And when you open these chests, this is actually that ewe's lungs. Oh, let me see. Sorry, I'm gonna change. I just want to move that out of the way. Is that you can actually see how expanded the lungs are and enlarged they are, and you can actually see.
Sorry, Dr. Fauna, I think you no longer are sharing your presentation.
Sorry. Boom. Is that better?
Yeah, we got you back up in presenter mode. Thank you so much.
So, do you see presenter mode or do you see my slides? Are you there?
Sorry, we see it the way we should see it.
Okay, perfect. So you can see like these rib impressions, and that's very classic of this fibrous lung because it's lost all its plasticity. And you can see the normal lung up in this corner that's nice and pink and soft looking. These lungs feel like liver when you feel them, and they have no give or no ability to expand and contract like a normal lung does anymore. And then again, the kind of what currently in, at least with practitioners that I talk to and what I see in my practice, we do not see a lot of this kind of ascending paralysis. It's typically, the descriptions in the literature are that it is characterized by juveniles. My kind of feeling, from trying to think about why we might not see as much of this anymore, either has to do with changing strains or has to do with the fact that if you institute control measures, the viral dose that kids are getting is much less than it might have been before we had control measures, and so we might not see this as often. Again, kind of trying to understand how this virus works and what it does and how it infects the animals. This virus has a tropism for monocytes and macrophage lineage cells. So blood monocytes, so white blood cells, this is one of the, cells that's infected. But again, only about 0.5 to 1% of circulating monocytes actually harbor proviral DNA. And proviral DNA is the replication of the virus. So this proviral DNA is sitting there, and multiple copies might be sitting there in the genome, but the replication of the virus is really restricted in blood, and it's not until you get activation of the macrophage when it goes into the tissues. You start getting viral replication. When you get viral replication and the macrophage is activated, you have macrophage-induced inflammation. That macrophage macrophage-induced inflammation, the pathology that we actually see is lymphocytic inflammation and fibrosis. And so if you look at this histologic slide up here, you've got all of these little purple cells. Those are all infiltrative lymphocytes. And then the big pink fluffy cells are actually abundant alveolar macrophages that are sitting in what should be alveoli. As you can see the normal up here where you have air in an alveoli, these alveoli are all filled with macrophages and lymphocytes. And so again, the pathology is caused by this inflammation. When we actually look for the virus is going to be in these macrophages. And so you can see that the macrophages the infected cells are much less frequent than the total inflammation that it's inducing. And again, don't forget, you have both differentiated macrophages that come from your blood monocytes. The virus can also infect alveolar macrophages of the lung and mammary gland, synoviocytes of the joints, which is the kind of tissue resident macrophage of the joint, and then microglial cells in the CNS would be the cells that are infected by this virus. And so kind of from the practical point of view, like how does transmission of CAE occur? The major route, what I would consider to be the major route, is especially in the goat, and I think there's still debate and research in sheep as to how it's transmitted, but in the goat, milk or colostrum from infected does to kids is the major route of transmission. And so, you know, in terms of raising dairy goats and why dairy goats might actually, it can be hard to control in the dairy goat if we don't institute some sort of measures, is because we tend to pull kids and then we pool milk and we feed milk back to them. And because the infectious dose of milk is only about 1 cc of infected milk to infect a kid, if you put one positive doe into your pool of milk or colostrum and you feed that to all your babies, then you can infect all of your babies. Now, with meat goats, is it very likely that the kids that are nursing a positive dam are going to seroconvert and become infected? Yes, but we are typically, most kids are only getting milk from one doe, so it's only that litter that's at risk versus every kid. You can have transmission from prolonged horizontal contact. Horizontal transmission from prolonged contact. And so these two does right here, this red doe seroconverted around 2 years of age from unknown sources, show herd. And then she was pulled off and isolated for the rest of her life with one other companion. This doe remained seronegative for like 3 or 4 years, and then around 7 years of age, she finally seroconverted after living with another positive doe for 5 or 6 years. And so that is the other form. I think that, again, this animal and the degree to which they are shedding, or animals that are infected, I think there's variation in shedding between animals, which may have to do with how they were infected and what their viral dose was. We also do need to consider minor routes of CAE transmission when we're looking in the totality of a control program. So you can have in utero transmission. There's older work suggested that about 10% of infected goats will transmit to their offspring transplacentally. So these kids are born with the virus and they may even be seropositive at birth, pre-colostral. I do think the work that I've been doing with herds that are still dealing with the virus, but have been using control measures for a very long time, I think that I see less of this in those herds than I do in herds that have CAE rampantly and are not instituting control measures. And so again, I think the body's viral dose or the viral load of the body probably has something to do with this. We do see venereal transmission, and What we do see is it's bucks to does, so CAE positive bucks, they will shed the virus in their seminal fluid, and so they can infect does during breeding. The does will have it in their genital secretions, particularly around parturition. And so you have to think if you have a positive doe that has a dystocia and requires a lot of manipulation, that is going to be a higher risk for that kid to seroconvert or become infected than a negative doe or a doe that has a easy birth. And then we also, again, it's shed in respiratory secretions. It may be shed in saliva. So thinking about things like drinking out of the same water bucket where it's being contaminated is a potential route of transmission. So when we start thinking about control, I think there's a lot of different approaches to control. To me, kind of the two key time points are prevention in that perinatal period, and particularly prevention of milk-borne transmission. And then when we start thinking about, and I know the second talk today is going to be about some of the serologic testing, and so serologic testing in this particular disease plays a really important role in surveillance and control. But again, our ability to use serologic testing is only as good as the serologic test that we're using, and understanding the dynamics of how serologic results for an individual animal may change over time. And so we can use serologic testing, segregation and removal of positives, thinking about how you milk if you are going to be dealing with, seropositive animals and seronegative animals. How do you isolate them from each other? Who do you milk first? How do we avoid iatrogenic transmission? So things like changing needles, cleaning milking equipment between them. And then again, because the vast majority of venereal transmission is male to female instead of female to male, testing bucks and only using negative bucks would be another part of a control program. So what are our strategies that we can actually use? So we need to kind of think, for every herd, this is going to be different. And it really depends on kind of where you start and what your goals are. And so eradication and prevention of introduction, I have a lot of herds that are in this category where they have either believed they have eradicated it, or we have enough longitudinal evidence in that herd to say they've eradicated it. And so really they're focused on trying to prevent introduction of the virus back into their herds. We have some herds that are so heavily infected that we are talking about strategies of trying to, get having two herds, having the core herd and then some sort of replacement herd that has reduced rate of CAE or no CAE. And so each herd is going to be a little different. As we kind of get CAE under control in a herd, we might start doing segregation, or test and removal. So test and cull or test and segregate. And depending on where a herd is in their, if they are attempting to get to the point of eradication, those methods and how we approach that are going to change over time. So I'm going to kind of go through what I see as some of the keys to, if a herd's goal is to reduce or eradicate CAE, and again, every herd is different. I do think that in herds that start to experience lots of complications of clinical disease, there becomes an urgency to try and deal with the virus. In herds that are heavily asymptomatic, there might be less urgency to deal with the disease. And so I think one of the biggest things is reproductive management. So in order to effectively control this disease, you need to have accurate reproductive records. You need to know when does are pregnant. You need to be able to think about how do we manage removal of the newborn, And there's removal of the newborn to reduce contact to the kid. And so that's something that I think is actually secondary to the reducing contact so they don't nurse. So the first thing you want them to do is not nurse. The second thing is to reduce just the contact with a positive doe. Um, and again, with good reproductive management, you should have an idea of when does are going to be kidding. They should be in the appropriate location so that staff and stuff are able to be watching them and pulling kids. And even further, you can go to the point of synchronization or induction of parturition so that we know exactly when they're going to kid, organize it so that you have staffing for that time, and then potentially even inducing them so that you're having the most amount of farm staff available to help when you're kidding out does. And so again, having some sort of system for removing the kids. If you are in a heavily infected flock or herd, trying to reduce litter to litter contact until the kids are dry. So these like some sort of tub or tote works really well. Cardboard boxes work really well, where each litter goes into a box until they're completely dry and then they can go into some sort of group housing. Might also help to reduce transmission of the virus. And then we get into the probably the most time consuming and painful part of a prevention program. And really pasteurized rearing is really what changed in the early 80s, really changed the transmission of this disease within herds that undertook pasteurized rearing programs. And when we talk about pasteurized rearing programs, colostrum is the bane of everybody's existence because you can't just heat it up for 15 seconds and kill the virus, because then you denature all of the antibodies and it turns into pudding. And so in terms of like what the approaches to colostrum management in a CAE prevention program are, one is to do heat treatment. The I don't know how many people have ever seen this, but the advent of the sous vide stick has actually made batch pasteurizing colostrum much easier to do. There are fancy colostrum pasteurizers. Depending on the size of the herd, a lot of the herds that we deal with are not huge dairy herds. I have commercial dairies everywhere from 50 goats to about 1,200. It's not really cost effective for them to buy a whole colostrum pasteurizer. So the sous vide method works really well. For colostrum, one of the things that I do recommend if they are going to use heat treated colostrum is that they don't pool and do record keeping. So when you pasteurize colostrum, have it labeled with what animal it came from, and then the babies, what baby numbers got that colostrum. And it helps if you know the status of the does, it helps you to know what babies are higher risk than lower risk, because heat treatment does reduce the viral transmission, but it is not zero. Um, a lot of big herds are moving to colostrum replacer. And colostrum replacer, my biggest thing with this is that not all colostrum replacers are created equal. And so I kind of have some guidelines for what we need to look for in a goat replacer colostrum. What I will say is you guys are very lucky in Canada. Saskatoon Colostrum Company is like what I would consider to be one of the best products on the market. This is not a paid advertisement. I actually think their product works really well. We don't have access. They do have the lamb and kid available in Canada. I think we've had some of it here. It's super expensive, so I use one of the bovine products. But when you are looking at colostrum replacers, one, you want the origin of the globulin to be colostrum and not serum. You want a minimum of 100 grams of IgG per liter. So it's really important to read the labels because often they report it on the cover as 100 IgG, and then you look and that's per dose for a calf and not per liter. And so the dose is often a liter and a half to 2 liters. You want more than 40% protein, greater than 20% fat, and then you want to make sure that the fats are milk, whey, or colostrum in origin and not vegetable. And so I for my biggest herds, colostrum replacer is often what they would go to preferentially, just because heat treating that amount of colostrum is difficult. Now, when it comes to milk, pasteurization is much easier. However, if you're commercial dairy, depending on the size of depending on the number of animals that are not able to be going into the bulk tank, they might not want to be using their own milk for pasteurization because they want to sell their milk. But if you are going to use milk pasteurization, it's a high temperature, short time. So 74 degrees, 165 degrees Fahrenheit is what we use in the States. I did do the conversion to 74 degrees for 15 seconds. And this can be done in pretty large batches. You can get commercial pasteurizers. This actually here is my own. I have my own goats. This is my own herd, and I can do 30 liters in a double in a water bath using a propane burner, and it takes about 15 minutes to get it up to temperature. So I can pretty much finish my pasteurizing while I do my milking. Most of my commercial dairies are using some sort of auto feeder, and they are using either milk replacer, and most of them keep some powdered goat milk around. Powdered goat milk's really expensive, and so we use it as we need to if we have diarrheal episodes when they're on the replacer. I think one of the keys for this kind of milk replacer feeding, especially the continuous systems, is you have to be on top of your clostridial vaccines or you'll clostridial disease. So for my herds that use this, the does get vaccinated 1 month prior to kidding, and then we start vaccinating them in a month of age, and we do it once a month until they are 12 weeks old. So they actually get a 3 booster series instead of a 2 to try to get them early for those that don't have a great maternal antibody, and then we give them the 3-shot series in case they did have early maternal antibody interference. The other thing that I will say is that regardless of how you manage the adult herd, if you start pasteurized rearing alone can greatly reduce the economic impact of CAE. And the biggest thing is that even if it's not perfect, reducing the viral exposure, the viral load to which animals are exposed is really, really important. And I think that has a lot to do with whether or not they develop clinical disease. And so I have this as a really good example. So which goat has CAE virus, right? This animal has CAE, the disease. This animal is infected with the virus, but again, because it was from a herd that is actively managing CAE and was likely infected through exposure to other animals from not that herd, as an adult, like the likelihood of that animal developing the same clinical signs as an animal that was infected as a baby with a high viral load from raw milk. There's a real difference, I think, in the progression of disease and what percentage of animals we see clinical disease in. Even in the original, like, kind of description of CAE, the worst affected herds, we only ever saw about 30% of the animals having clinical disease. I think you can further reduce that even if you still have viral infection around by instituting some of these control measures. I'll talk a little bit about CAE diagnostics. So serology really is the mainstay of live animal diagnosis of CAE. And for many years we used an agate gel. Now the standard is ELISA, and in the United States, we have two ELISAs available. We have the VMRD ELISA, which is what almost all of the labs use, and then Minnesota uses the ELI test, which is from Europe. And so these are really important way to the control of disease at the herd level, but we also have to understand the limitations of the test. I will also mention that PCR is available, at least in the United States, at several labs, and they will take whole blood. But you have to remember that this is a test for proviral DNA. It's going to demonstrate virus-infected cells, but because the infection rate of cells, which are the monocytes, is very low, and monocytes are already a smaller proportion of white blood cells than some of the other white blood cells, this has a low sensitivity. And so one of the things that I'm seeing producers do here when they don't consult with the right people is they will do, especially in herds that believe they have eradicated CAE, they'll do a serologic test. It comes back positive. So then they do a PCR test. And if that PCR test is negative, they believe the serologic test is wrong. And I think that is a recipe for disaster. So when we think about retroviruses and we think about the fact that they are lifelong infection, that they produce, that the immune response is a non-neutralizing antibody, and this virus can hide in the body, to me, if we have confidence in the serologic test, that the serologic test is being run properly, and if you're working on an eradication program, to me, I can say that in a herd, I will treat a seropositive animal as an animal that has an infection. And when we're thinking about eradicating it, it is always better to have a false positive than it is to have a false negative. What are the diagnostic challenges? And I think some of this is going to be talked about in the next talk, but with serology, test agreement, so test agreement between labs, test agreement between different types of tests. Not all tests are created equal. What validation has been done? What are the cutoffs? So the VMRD test with their kit gives some recommendations for cutoffs. Probably one of the kind of classic ones that we've experienced here in the US is with sheep, and that the cutoffs that are reported for goats for the VMRD test really are not low enough for sheep. And so herds that were working on eradicating OPP, they actually had to either move to using the ELI test or they changed their cutoff based on the percent inhibition of the VMRD test. And then quality control is important. So if, talking to your lab, does your lab, the CAEV's lab here, they run all positive samples in duplicate. So if they get a positive, it gets rerun again to ensure that it's a true positive. And then again, PCR, we kind of talked about, there's a low infection, difficult to have a false negative. And then there is not offered commercially in the US. There are a couple places in Europe that do this where there's real-time PCR for viral RNA in peripheral blood mononuclear cells. The issue here is that the viral replication is suppressed in those monocytes. And so there's not a lot of viral RNA around. So what are some of the CAE testing strategies that we need to think about? So one of the questions is, at what age do we start testing? If you are in the mode of eradication and you are dealing with positive animals, if kids are getting colostrum that's heat treated from positive does, you're going to have maternal antibodies that could interfere with the true status of the kid. And so we need to wait until maternal antibodies have waned in that situation. And then there's also the issue of delayed seroconversion. So what's reported kind of on average is it can take up to 6 months for an animal from infection to seroconversion. So depending on how many times a year you're testing, when you're testing, you need to think about how that might impact your when you start testing and then how you interpret those results. In terms of the this is just an example of as a sheep herd that we've been working with. And again, we looked at lambs from seronegative ewes and seropositive ewes at less than 6 months of age, and we had a lot more positives in the lambs from the positive ewes. The question to me is, at less than 6 months of age, are these truly infected lambs and that's their own antibodies, or is this still maternal antibody? And so these animals are due for a retest. When you have a higher or low endemic level is going to affect what testing strategies you might take on. And again, are we starting, if we have a really, really high level, is it worthwhile testing everybody? Probably not. It's probably better to institute some sort of control strategy and then test replacements only. If you're a very low risk herd and you think you're close to eradication, then it does matter testing individual animals and then either culling or isolating animals that come up positive. And then thinking about risk of transmission, I have a lot of herds that use a segregation. So they test the negative herd once a year and then they have a positive herd, and animals move one direction. So they move from negative to positive. They don't bother testing the positive barn anymore. Once they test positive once, they're considered to be a positive animal. And then how they deal with babies born in the positive herd and babies born in the negative herd, and when those animals get tested is also part of thinking about how we control this disease. Also identifying, high risk periods. So for me, for babies, the periparturient period is the high risk period. The risk of transmission during being born, and then the risk of transmission if they either get given raw milk or colostrum or accidentally nursed from mom, if we're trying to stop that from happening. Sometimes, best laid plans, they still get in there and they are gonna nurse. You think, well, I want to know as close to kidding what her true status is. Well, that comes with problems. Pre-breeding is probably the most accurate time for titers, but you're going to miss some animals that have delayed seroconversion. So maybe they aren't seroconverted yet, but they are truly positive. If you try to do pre-kidding, right? So this would be the highest risk time for transmission. We know based on literature that pregnancy seems to drop their titers. And so you could have false negatives in the periparturient period on does when you really want to, know if they're positive or negative. So, these are all things that you need to weigh when coming up with some sort of testing strategy. I tend to do mine pre-breeding. Identifying high-risk groups, so segregation and one-way flow, and then identifying high-risk animals. So high-risk groups are going to be, you have your positive herd and a negative herd, and then high-risk animals are like the offspring of the seropositives. They might be raised alongside the offspring from the seronegatives, but that individual animal has a higher risk of being seropositive at some time in her life. And then if they nurse their dam at birth, even if it's a herd that has CAE, even if that is a seronegative dam, that would be something where that animal would still be considered higher risk than a kid that did not nurse their dam. So, I think that leaves about 10 minutes for questions. That's what I was aiming for. So these are, I hope I tried to kind of give a big overview and some kind of ideas about how we might go about testing or what strategies. If people have specific questions, it's really hard to just give you, here's the testing strategy or the control strategy that you should use for goats, because every herd is so different depending on where they are in terms of the incidence of disease, the incidence of clinical disease, the management system for that farm. it's very complicated. Every herd really needs their own like custom program, so to speak. But yeah, that is what I have. If anybody has any questions, I don't know how many of you guys do commercial dairy work, but if you are in a commercial dairy and there's a goat being ridiculous in the milk parlor, it's always La Mancha. At least down here. I don't know how many launches you guys have up there, but there's always one.
Thank you so much. That was a really great presentation, Dr. Smith. It gave us a lot to think about to how we communicate with our producers and strategies for testing and how it can differ between herds and all those things that we need to consider when best setting up a strategy. I think there's one question here from Dr. X Crawford. In colostrum replacer feeding, how much colostrum are you recommending feeding and how many feedings?
Yeah, so that's a good question. So again, it's like weighing the expense of the colostrum against how much they need. I try to get them to do 2 8-ounce feedings, so 16 ounces in the first 12 hours. And that's for a standard sized dairy kid.
And then how many feedings maybe do you do after that?
So I do 2 feedings. So I do 2 feedings of colostrum replacer, and then what I will do at that point is I will transition them to milk after the 2 feedings, as long as they take all of it really well. Now, if they don't take that whole 16 ounces in the first 12 hours, I will just start like adding milk to make up the difference until they get all of that colostrum in the first 24 hours, if that makes sense.
Yeah, that's great. Just a reminder for everyone who jumped on a little later, if you just put your message questions in the chat, we will be able to address them, and that the presentation deck will be shared with the recording after the presentation. Currently, I don't see another question for you, Dr. Smith, so I might just ask you about your experience with the sous vide, if you don't mind.
Yeah.
Have you done any like testing to see the efficiency of how the sous vide works on CAE specifically?
So the sous vide, so because the work was done to establish the time and temperature for heat treatment, when we started using the sous vides, what we were doing was serially to monitoring the temperature of the colostrum and ensuring that our sous vide method was keeping the colostrum at that temperature for the sustained period of time. And so I felt like instead of testing virus laden colostrum and looking for virus, if we could establish that the sous vide was doing what the original heat treatment protocols that showed that CAU was reduced, as long as we were hitting those temperatures for that period of time, I felt like that was adequate from a practical standpoint, because getting people to do heat treat of colostrum is like one of the hardest things to do, and the sous vide really changed that.
Yeah, and we have one other message that popped up into the box by Dr. Paula Menzies. Some papers from Europe show that serological status is variable over goats in time, and viral shedding in the milk may be occurring when serology is negative. Have you found something similar?
So what I will say is that there are animals. So I don't know that I have enough information on like specific cases to say yes or no. What I will say is that we using the VMRD test, I have there's what they consider a positive and what they consider a negative test. And then they have their suspect zone. If a goat ever hits a certain percentage inhibition, and to me, typically if they're over 60% inhibition, that goat is positive forever. I don't care what any other test says, and we will in the 50s and 60s on occasion we'll see them drop into the suspect zone or high negative zone, and that animal to me is always positive. So I haven't looked at shedding of virus versus the serologic test. in these positive herds. But a lot of times, I think for us, for the herds that I'm working with, it's such a one-way street. Once they test positive, we often don't test them again. They are treated as positive forever. So I think that's comes into your strategy, right? If you have herds that are serially testing and they're taking does that were positive one time and wanting to call them negative because they're negative the next, I think that is a really bad strategy for control.
Perfect. Thanks so much for answering that. And just one other question from my notes of what we wanted to cover. Could you just maybe touch on, for our herd that's trying to eradicate or has very low prevalence, the best testing strategy and quarantine strategy for new arrivals to best limit that CAE risk?
Yeah. So what I would say is for if we start with the herd, it's the core herd. So the core herd, if we're, and I deal with a lot of these herds, I do a lot of seed stock and show dairy goat work, and they're pretty obsessed with CAE testing and keeping the herds negative. And so in those herds, if we are still in the eradication and segregation phase, so like I think I showed the picture of the two Nubian does that live together. Like those were the last two positive animals in that herd. And they lived separated, segregated more than 6 feet from any other fence line, from any other goat. And in that herd, we tested every 6 months until those two does died. And then we tested every 6 months for 2 years after they died. And then that herd now tests once a year. If the herd has been seronegative for a long time, we will do annual testing. If they've had an incursion, and this happens especially if you have show herds where they're going out to shows or doing things, intermingling, like mingling or being near other herds, you'll get unexpected seroconversions on an occasion. Positive animal in your herd, the ideal thing, I have them go back to 6 monthly testing. And then for herds that have been negative for a long time, once a year testing, annual testing. And I tend to do it pre-breeding because it means most of my kids that are going to be bred to freshen as yearlings will be old enough to test. I don't have the issue of the nadir of the titer from pregnancy. And so I can test in that early fall period, and most goats will be old enough to test. And I think it's kind of the safest time of year to test. VMRD also has, I don't know, on their label, they do have some information to suggest that maybe vaccination may interfere or make false positives. So I do try to recommend that people do their testing not at the same time that they have the goats in it, like not at the same time that they've recently vaccinated their goats.
Perfect. Thank you so much, Dr. Smith, for that great answer and for joining our Ontario Animal Health Network webinar to present all that information. We just don't see any more messages in the chat. So if anybody does have any additional questions for Dr. Fauna, you can put them into the chat and we'll see if we have time at the end to address them. And her email is also up online there. So if you can grab that and ask your questions as well. Okay, and we are now going to switch over to Dr. Davor to present on his trial with VMRD and his experience using the hyphen analysis. So we will let them figure that out. Thanks, Michael. And so Dr. Davor completed his Doctor of Veterinary Medicine program in Croatia, and then he worked in swine practice. He went on to complete his master's at Brock's University, followed by a PhD at the University of Guelph. He currently works at the Animal Health Laboratory in Guelph as a virologist and immunologist. Davor's group carries out well over 150 different tests, from classical virology to fully automated high throughput procedures. Dr. Davor also develops new diagnostic tests and works on improving existing tests. Although he primarily provides laboratory and consultation services to veterinary practitioners and agricultural operators in Ontario, he also collaborates with colleagues and universities throughout the country. Thank you, Dr. Davor, for joining us today.
Uh, Thank you very much, Lisa, for inviting me. And actually, you made my first 2 or 3 slides half redundant because I was just going to introduce myself. I know some of you guys on the webinar know me, but many don't. So, anyways, you know, I work for the Animal Health Lab, and we are we were formed in 1997 by merging Ontario Government Lab and labs with University of Guelph labs. So we are University of Guelph employees. And we work with practitioners, with government agencies, with colleagues at other universities. We're heavily accredited because lots of things we do, we must be accredited for expert purposes. We are accredited by AVLD, and also we work closely with CFF, all the foreign animal diseases. So we have tier 1 network lab, and we can do pretty much testing for any foreign animal disease that CFI tests for. So we have roughly, well, almost 1,000 tests in-house, and I'm a virologist and immunologist, so my section does pretty much all the testing for viruses and all immunotesting for not just viruses, for bacteria and some parasites as well. And right now we have 30 ELISAs on our scope, and actually 29 are antibody ELISAs, 1 is antigen ELISA. And today I'm just going to be talking briefly about what we've been doing for CAEV/MBV testing. This kind of started before I was in charge of this part of the lab. So I think that we've been using the CAEV ELISA since around 2008 and MBV somewhere around 2010. And there's been changes over years. Historically, it was decided that IDEX ELISAs were more appropriate for CAV testing of goats, and hyphen biomed or ELITest ELISA was more appropriate for sheep. We did test VMRD a few times, and kind of the change that I'm going to be talking today about occurred because IDEX discontinued one of their kits that we were using before, and then we went to the second one, and then they discontinued completely their CAV MBV testing portfolio in summer in 2022. So about the time when it was happening, we still had a whole bunch of IDEX kits, and we tested in parallel some 758 samples, and this is goat samples. This is not sheep samples. So we tested them, and we found actually really good correlation between IDEX and ELITest. There was just one large submission that actually IDEX detected a few more positives than the ELITest detected. But generally speaking, that was sufficient in my view to justify switching or introducing hyphen ELITest as a primary test for goats as well. And people did ask me, so why didn't we go with VMRD? Well, one of the reasons is that some 5 years ago, I was involved with a study where we tested a whole bunch of samples and from sheep and goats from herds that were more or less defined as positive or negative or had history. And for sheep samples, we found that VMRD sensitivity was really not even close satisfactory for what we wanted to do. And now that IDEX got discontinued, we did retest because we had a whole bunch of those samples from the project in a freezer, -80 freezer. So we retested them with ELITest and tested them with VMRD. And actually for goat samples, didn't appear to be much of a difference. Now, I need to add that both ovine and goat samples, or most of those ones, were also confirmed by PCR, and some of them, sheep samples, were also confirmed by sequencing as confirmation of the true status as positive. So there's been some issues historically always with those unexpected reactors with ELITest ELISA, and I thought that after I've heard a few times that some of the samples on ELITest weren't the ones that they were supposed or expected to be. I did decide to go and look at more samples, comparison, more sample testing between VMRD and ELITest, because this study that I'm referring to now was done 5 years ago, and then I thought, well, maybe there's different viruses, there's different samples, there's different genetics, whatever it is. So then we in parallel tested all those samples. Now the 583 samples that were from 40 different AHL submissions. And here on the top of this, and it's actually kind of small, but I zoom in here, there was 10 submissions in which results or number of positives did not match between VMRD and the ELITest. So I started looking then case by case because I wanted to see what's happening with those ones. Are these ones big differences? Are they around cutoff or what it is that's making them so different? So this is an example of this submission of 141 samples. And when I looked in histories, I found actually that this case had 2 submissions, one before and one after, and they all had a significant number of positive samples. And when I looked at or compared samples, VMRD percentage of inhibition and ELITest OD values, it was clear that results match real well with strong ELITest positives. And there was one exception that, there was one kind of weak reactor of VMRD, which was around borderline across, cutoff for ELITest. So I keep on looking at other cases. So this one was the one from 2019, and actually this one was PCR positive confirmed. And in this one, again, the same kind of thing happened, that the stronger positives on ELITest were positive on VMRD, and weaker positives on ELITest were negative on VMRD. And then I looked at this submission. Now, this is the one that was a bit confusing to me because I could see there was some weak reactors on ELITest, but they were all negative on VMRD. So I looked in the history, and again, I need to qualify my statements a bit here because I identified that this client submitted samples since 2014. I do that based on the address, name of the client, and clinic. But I don't know if this address of the owner is associated with multiple flocks at different places. I don't know that. I just go by the address and code, which may be just the billing code for the clinic. I don't know. But anyways, this is somebody or this client, this owner submitted to the clinic many, many times. And there were some that were since 2024 occasionally reactive. Now, this last submission had I didn't have those older samples to run VMRD on them, but the last ones that were negative VMRD were somewhat less of a positives than the ones that matched before. And I keep on looking. So this submission, next submission of 74 samples, I didn't realize before, but when I looked at the owner and everything else, I realized that this is the first submission, and then those 3 submissions later, they're all from the same place. So basically, they were confirming or retesting the samples that were originally reactive. And here actually was the animal IDs were entered in the system, so I could identify, I could see that again, this was somebody who's been submitting since 2015. And since, there was no submissions between 2021 and 2025 that I could identify, but since 25, there was a small number of reactors, and clearly there was this one code, 3264, which tested positive 4 times in a period of 4 months. These are all still weak, on the weaker side of ODs for the ELITest, but these ones were all negative by VMRD. So I also looked at some cases where actually VMRD and ELITest agreed, and clearly again, that's pattern of strong positives agreeing and weaker ones not was apparent. So basically I put all of them in the next few slides, which is if you start with the strong ones, they agree 100%. And as you start going down to weaker ones, you start getting disagreements between those two tests. And finally, there was one exception. That's the one that I mentioned before. That's VMRD was actually positive and LE test was negative. So one thing that's a bit confusing here, or what's confusing and somewhat complicates, way you can present stuff, is that LE test, this hyphen LE test, they use floating OD value as a cutoff to determine whether the sample is positive or negative, which means that on the same run or in between runs, sample with OD value of 0.25 can be positive and next time could be negative, which is a little confusing and actually unique. All the other ELISAs that we use in my lab, they all have a fixed normalized cutoff, but not the floating OD as this. And I understand why they do it. Like, depending on how you set your cutoff, you're gonna change the test performance. Specificity or sensitivity will be impacted one way or the other, and there's always some overlap. And depending on what the assay is purpose for, people who develop them accept that there's going to be some low false reactor rate, be it false positive, false negatives, depending on the purpose. But when I look at numbers, and this is just the crossing line at positive negative sample, but actually I have like a couple thousand samples that I ran through this calculation. So I thought, can I actually get something that's going to be more like other ELISA that we use to have a normalized SP ratio or SP percentage? And it immediately became kind of clear to me that the cutoff is at 25%. I didn't realize that before, but then it hit me that that's exactly what they do with the hyphen Biomed LE test, because they normalize the OD and they divide it by 4, which is 0.25, which if I multiply it with 100 is 25%. And I used to be good at math, but I'm no longer good at math that much. So just to make sure that I'm not seeing something that doesn't exist there, I asked ChatGPT, Grok, and Gemini the same question. And they all saying, yeah, actually, mathematically, the way they calculate for floating OD is the same as if I would use 0.25, but because here I'm normalizing the cutoff and here I'm normalizing the sample. So cut a long story short, we could report, and we'll do this change soon in our system, that basically we can express results with a cutoff of manufacturer recommended 25%, that those samples are reactive, and it's going to be easier to compare things that happen over time. Will this solve problem with unexpected reactors, unwanted reactors? No, it will not, because the LE test manufacturer specified specificity is 99.3%, which is not bad at all. When you think of it, it's pretty high for an ELISA test. But what this means that if you test 1,000 goats, which are free, which are negative, you'll get 7 reactors. Or in low prevalence herds, like if you have low prevalence at 1%, you're gonna basically detect all 10 reactors or true infected animals, but you're going to generate 7 reactors for those 10. So in low prevalence situation, the positive predictive value of ELISA with 99.3% specificity is actually 59%. If you go in high prevalence situation, then situation changes and the prevalence is much higher. So I did look also, while I was going through those numbers, into, okay, so how does this work in real life? Because basically, if we generate 7 reactors for 1,000 testing, that That means for every 140 samples, give or take, plus or minus, you're going to generate a false reactor. And I did find this one large submission that had 4 reactors original, and that was retested 10 or 14 days later, and I could identify those samples, same clinic, same person, same animal IDs, and they did go from well, low positive. One was high positive, but rest of them were kind of lower side. They went down to well, some of them are weak, still reacting, but some of them are clear-cut negative. So yes, in this case, the test did produce some presumably false reactors, because 2 weeks after the first well, sample collection, you know, that this if the animal was truly infected, you wouldn't lose such a big signal just a matter of a few weeks. Now, on the other side, I thought I'd look into, okay, so how often do we get well, signal that's more or that's less than what manufacturer recommends in terms of specificity? And we did test since introduction of, or since switch to hyphen biomed early test. We tested almost 15,000 samples that are good samples, and overall the percentage was 8.88% that were positive. But the ones that produce less than 0.07% reactors, like these are only the cases that had 100 samples or more. So we do occasionally get 1 reactor for 400 samples, but the other times we get 0 reactors for 240 samples. So this kind of suggests to me that it's not just the test, it's something that's in those samples that we receive. And certainly this unexpected reactivity can, it can arise from a number of different reasons. Of course, if you have poor quality sample, which is generally speaking not the case, usually we get good quality samples, you have a hemolyzed sample or contaminated sample, it can give you reactivity. Then the other thing that is, explainable is if you have something that's around a cutoff, and it can go, one time you test it, it's slightly below the cutoff, the next time you test it, slightly above the cutoff. So yeah, something that's lingering about the cutoff value, that can go up and down, but shouldn't go from strong positive to negative, and the next time produce even more confusing results. But certainly there's like antibodies, they don't recognize the whole microorganism or whole viruses, but rather they recognize epitopes. So if you have infection with a related virus, you may have some low-level cross-reactivity that's not necessarily reacting to CAEV or MBV, but could be to other retroviruses or retrotransposons which are inserted in human and animal genomes, and which sometimes occasion can cause some kind of response. It's really poorly understood what can cause those kind of things, but it's not just for MBV, CAEV, but it's for a whole bunch of other things related to antibody testing. Now, the other thing is cross-reactive antibodies, and Dr. Smith mentioned vaccination, primarily vaccination with kill vaccines. This is something that's been well documented in turkeys, in breeded turkeys. If they get kill vaccines and then they send us samples for mycoplasma or salmonella testing, like half of them may become positive on those tests, and they just falsely reacting to whatever it is because they produce broadly reactive antibodies that somehow bind to the acid. And could be also some non-specific binding due to serum components. If you have high lipemic or global enriched samples, it can cause occasional false reactors or unexpected, not necessarily false reactors, but unexpected reactivity. And also ELISA antigen composition, depending on type of ELISA and how antigen was purified and how antigen was coated, how plates were blocked and so on, a whole bunch of little technical things that can cause unexpected reactivity. And basically, ELISA performance, when you look at it from one perspective and the other, will be deeply influenced by what it is that you want to do. If you want to identify truly unaffected animals, you're going to lose some sensitivity. Your test will be specific, but you will need to accept that some false negatives will occur. On the other hand, if you have really sensitive tests, it will minimize false negatives, but you have to accept some false positives, because somebody tells you that there is a ELISA test that is 100% specific or 100% sensitive. I'm just going to say they haven't tested enough samples yet, because no antibody ELISA that I've seen, even good ones, are 100% specific and 100% sensitive. So what can we do? I mean, I do occasionally get phone calls about those unexpected and confusing reactors. And generally speaking, it's primarily because of situation with low prevalence testing, when the positive result is a maybe, so to say, in some situations. And the best to do is to wait, retest, or confirm with different tests. Now, in a prevalent situation, again, false negatives can occur. If you want to eradicate, you want to detect all of your potential reactors, but still, if you're not sure, retesting and using a different test would be warranted. Now, for a whole bunch of tests in my lab, we do have secondary tests, and example would be this mycoplasma ELISA that we do for chickens and turkeys. We do a couple 100,000 a year, and one of those particular tests produces those unexpected reactors over and over again. But we have hemagnesia inhibition that we can then use, which is, well, it is more specific, also it is less sensitive. So you gotta find and fine-tune difference between specificity and sensitivity even with confirmatory testing. And the challenges, as Dr. Smith also mentioned here, and she went in detail of some of this stuff. Well, it's the biologic characteristics of the virus and infection that these viruses cause, and the name is lent to slow. So everything is here different than in your typical acute viral infection. If you have, influenza infection, you're gonna get exposure, incubation. The virus gonna virulently go to target organs, it's going to replicate there, antibody will be developed, and it's kind of clear-cut situation for most acute diseases. Now here it's all slow. Seroconversion can be delayed, and shedding of the virus may, in some situations, certainly be intermittent. We did do use PCR in that project 5 years ago, and it worked reasonably well on better for goats than for sheep, and reasonably well on case level, but not necessarily that sensitive on a single animal level. So, as again Dr. Smith mentioned, if you use PCR to confirm that, if you get a positive, that's confirmed. But if you get negative, it may not be confirmed that it's negative because of the biology of the virus. So this goes back to all different factors that involve anything from biodiversity, host factors, how animals were infected, concurrent infection, stress, and of course, test performance factors. And I thank you for your attention, and I'd like to just acknowledge everybody in my lab for their hard work and dedication. Thank you.
Thank you so much, Dr. Davor. That was a really great presentation, really helping give private practitioners some good tools on how to have those conversations and on interpreting tests and choosing which test works best for the herd type. And it really hits home on Dr. Fauna's quote, which she was talking about in a herd where they're trying to eradicate, you'd rather take a false positive than a false negative. And that's really highlighted in your presentation, and very helpful to hear about that expected rate of false reactors and how to interpret that and troubleshoot it. If anybody has questions for Dr. Davor, they can put them in the chat, and maybe I will ask one in the meantime. If you have a low prevalence herd, and it's a herd that is looking to eradicate, which of the two tests then, with the research that you've done into the two tests, hyphen versus ELISA, would you be recommending producer use?
Well, in the situation where you want to detect the last reactor that you have, you're going to have to use the more sensitive test, and if that more sensitive test will falsely identify one more or whatever number of more animals, it may be the price that you need to pay, but there's no way around it, because if you use more specific tests, you're going to miss some animals that are truly positive, because generally speaking, more specific means less sensitive, and more sensitive means a little bit less specific.
So that higher sensitivity test in these situations would be the hyphen then?
Yes.
Okay. Yeah, no, thank you so much for clarifying that. And I don't know, we don't have another question in the Dropbox, so I'm going to just keep firing you some of the questions that I've gathered from practitioners and veterinarians that were hoping to attend this. Do you mind just speaking a little bit on just how those tests identify different proteins within those viruses, and why maybe some tests work different on some of those really early infections?
Yeah, well, the test performance is also going to be influenced in about what they target, right? So if there is and for acute infections, it may not make much of a difference because it's so fast. But in something that takes such a long time to seroconvert, test which detect antibodies against viral proteins which are expressed early in infection will become more positive earlier. So sometimes it may not be that difference in performance is complete forever, but it could be that difference in performance is based on the time when sample is collected. And again, same thing as with acute convalescent. Don't test for antibody 3 days after animal was exposed to virus, because there's going to be no antibody there. It's going to be just the virus. So early infection, you're going to want to test for virus, and later you want to test for antibody. And if some parts of the virus are stimulating antibody response a bit more, those antibodies will be easier to detect earlier. Again, that's kind of convoluted for CAEV, MBV, or for small ruminant lentiviruses, all the other retroviruses, because there's no sterilizing immunity, so to say, and because the infection process is long, unpredictable, influenced by so many other factors that it remains to be a lot of things to be learned.
Okay, and when a test is tried in other countries with different demographics, how do the different strains of virus maybe affect how that test performs in another country versus how it's performing in Canada or regionally?
Well, see, we don't have a test that was developed in Canada based on Canadian viruses and whatnot. So if you have test that is developed in different country, you will need to test how it performs with samples from your own country. And again, before my time, I know that there was comparisons that were done between a whole bunch of different ELISA kits for sheep and also for goats as well. For goats, I don't think there was that many, but for sheep, they tested 4 or 5 different ELISAs and compared them with CFI test, whatever it was at the time. And that's when it was decided that for the purpose of whatever testing was intended to, the hyphen biomid ELISA was the most appropriate at the time for sheep samples, and IDEX for goat samples.
And we have a question by Dr. Fauna Smith, and you're unmuted, so you can go ahead.
I was just gonna, well, I was gonna kind of add to that we've actually been doing kind of repeating some of what you just showed here in the States, looking at the hyphen or the LE test versus the VMRD and actually finding quite similar results, particularly in sheep. And the sheep, it's like if we have sheep herds that really want to eradicate it, we have gone to using mostly just the LE test. So I just wanted to say that like our results are very similar to what you guys are finding. We did find if we dropped the percent inhibition cutoff on the VMRD down to 21%, then we got better agreement.
Are
And
you,
did you,
go ahead, Dr. Davor.
sir, did you maybe try to adjust the early test cutoff, to avoid some of those unexpected weak reactors?
When Minnesota tells you, they tell you like their N ratio, they tell you above 2 is positive, but on their test results, but then when they give you when you talk to them, they say, well, 1 to 2 is actually suspect. And so depending on how we kind of looked at some different cutoffs to see how it made the interaction or how it compared to the other test. What I will say is that from a practical standpoint, the herds that were trying to eradicate it were not making progress when they were using the VMRD test. When they were using the VMRD test per the VMRD test cutoff until they dropped their cutoff.
And can you clarify for us, Dr. Smith, when you were editing, like playing with the value of the VMRD test, was that in sheep and goats or just sheep?
So just sheep, and it's based on a paper out of Washington State that where they did a whole bunch where they had confirmed positives and they looked at the VMRD test performance and they felt the cutoff for sheep should be 20. It's like 20.9% inhibition.
Yeah, thank you for clarifying that for everyone. Yeah, some people might be aware that that VMRD test cutoff point is being edited or changed for sheep, but we haven't been seeing that in the goat herd. So thanks.
I will tell you that our lab here has slightly different cutoffs for goats than what is on the kit, and that's based on their own internal validation of the kit.
And Dr. Palamenti has a quick question here. And she's naming the antigens that I couldn't remember the names of off the top of my head. So thank you, Paula. The VMRD is a single antigen test, and the LE test has 2 antigens. I've read that animals develop antibodies to the P23 earlier in infection and later to the GP135. Do you have any thoughts on how this might impact using the 2 different tests? This is what I was trying to get Dr. Davor to discuss earlier about
Absolutely, it's going to have an impact.
Can you see my slides?
Yes, we can.
I have little diagrams of both of them if you want to use them to talk about it.
There you go. Thanks, Dr. Smith, for facilitating Dr. Davor.
Well, certainly, I think that LE test can detect antibodies. Certainly, exactly what Dr. Menzies is saying. And again, I don't work for Hyphen Biomed, I don't work for VMRD or for IDEX for anybody else. So I can only form my opinions of what I've seen. And I'm not going to, again, say that one test is perfect because in my experience, there's no perfect antibody detection test. But it's bottom line is what is that you want to do. Like if you really want to eradicate disease, you want to use LE test because it is more sensitive, and it's going to cause false reactors. Like it will, it simply will, and more you test, higher chance that you actually want to cause some false reactors. With VMRD, if you have a closed herd and you have no challenges, and you want to use VMRD as more specific test, go ahead and use it. But depends on what you want to live it or your client, because it's, the clients who end up with those headaches, and I fully understand it. But do you want to just postpone finding out, or it depends on management, and I don't even pretend I know all that's involved in eradicating such a nasty disease from a flock or a herd. But certainly, if you want to eradicate, then you're gonna have to call some of the false reactors because you weren't sure what they are, and I don't know, is there any other way to do it because of the nature of this disease, or those two diseases, because they're somewhat different.
Okay, thank you so much. And we've only got a couple minutes over time, which I think is pretty impressive. So thank you everybody who joined in person, and for everybody who's watching online. Thank you, Dr. Smith and Dr. Davor, for joining us today on the Ontario Animal Health Network's CAEV webinar. I know I learned a lot, and I think a lot of practitioners have left here with some really great tips on what they can implement within their herd. And we're going to get Dr. Fauna Smith's presentation. Dr. Davor at AHL is always available for further questions, as am I at OMAFRA. I can put my contact information in the chat as well for anybody who's looking for more questions or some more support with their Ontario herds. So thank you everybody for taking the time to join us, and I hope you have a great evening. Thank you again.
Thank you.
Bye-bye.
Thank you. Bye.
Thank you.